Before we start, I'd like to thank our corporate partner, Orion Pharma UK, who has sponsored this podcast, enabling us to further our mission to support the well-being of our pharmacy family. Welcome to A Dose of Wellbeing, the Pharmacist Support Podcast. I'm your host, Melissa Cochran, Wellbeing Development Senior Manager here at the charity. Today, we're delighted to be joined by Dr. Danielle Adams, a pharmacist and expert in supporting mental health and neurodiversity in organizations. Danielle is a UK registered pharmacist with a PhD in education and psychology. She brings together clinical work, research, teaching, and lived experience to help healthcare teams and businesses take more inclusive, practical approaches to mental health, neurodiversity, and intellectual disability. She also publishes in academic journals, reviews research papers, contributes to national guidance, advises organizations, and is a trustee for Mind in Mid-Hertz. A major focus of pharmacist support this year and beyond is ensuring we offer neuro-inclusive resources and support. We're excited to explore neurodiversity across future podcast episodes, and it's wonderful to have Danielle with us for our first neurodiversity-focused episode. So thank you so much for joining us today, Danielle.
Thank you for inviting me. And it's been lovely to come up to Manchester, a city where I did my pharmacy degree back in the 80s.
Wow, that's great. So it's kind of a trip back to an old haunt.
Absolutely, but there were no trams in those days.
So it's changed a lot.
It's changed a little bit, yes.
Well, I thought it might be interesting to start a bit with your story because what you bring is quite interesting, being a pharmacist with your doctorate in educational psychology and all this interest in mental health and neurodiversity. So I thought we might start a bit about you and your story. What led you into pharmacy? What led you to specialize in the areas that you do now?
So that's a good way to start, I think. And I first went into pharmacy because I like science. I like biology and chemistry, and I like talking to people. So, like many people of 18 years old, you don't really know what you want to do, but it sounded like a cool idea. So I went into pharmacy, and throughout my career, I've worked in different branches of the profession, mostly hospital, a little bit community, pharmaceutical advisor roles. And then in 2012, I took on a role that was not in my comfort zone, something a bit different as a mental health pharmacist. So I was very fortunate, had the opportunity, got the job, but then I had to do the job. So I decided to upskill myself, taking a postgrad certificate and diploma in psychiatric pharmacy. But what actually I found informed my clinical practice was that I have a son with a learning disability and autism. So I was an expert with lived experience, and I became very involved in learning disability services. And we often think of people with lived experience as being the patients, the service users, but I was using it really for me in how I approached my clinical practice.
That's brilliant. And I'm sure that your experience will have added a lot of value to your work life. And I think a lot of the guests that we have on have very interesting personal stories like that have led them down paths they maybe hadn't planned to go down. So how do you describe neurodiversity? And, what do you think people maybe understand or misunderstand about what neurodiversity is?
So I think it's really the natural variation in how people speak, how they speak about the world, how they interact with the world, how they process information. And I think what the misunderstanding about it all is that I think people think it's quite rare. And maybe it's because the language we use around people being neurotypical. Say someone's neurotypical, it means everyone else is not typical.
Right.
So I think there's lots of people that are not diagnosed, if we want to use a medical model. And I think that causes confusion because our systems are very much designed for neurotypical. I don't really like that language, neurotypical, but I'm going to use it because I'm not sure how else to explain it. And I think that's what's happened. And many people at the moment are saying there's far too many people being diagnosed. Well, is it there's too many people being diagnosed, or is it just our systems have just become more and more suited to people who are neurotypical?
That's an interesting way of looking at it.
So, and I think that with this natural variation is also about the way people process information, how people learn as well, learning styles.
Yeah, that's great. And in the workplace, if a workplace is trying to be enlightened, supportive, aware of neurodiversity in the workplace, what are some ways that it can kind of show up in the workplace?
So one of the things I think is really important to consider in all workplaces is that first job. So one thing I didn't just mention, or I understand by neurodiversity, is that it includes conditions such as dyslexia, dyspraxia, autism, ADHD. And in the school setting, if you have a diagnosis and then you go to university, you get extra time, there's extra support. But when you go to the world of work, deadline is the deadline. You can't say, I need extra time because I'm dyslexic. That may not work in the setting you're in the context you're in. So that's the first thing I think we need to think about. We need to be really clear how we want to ensure that people with a diagnosis of some dyslexia or anything that really is affecting their processing speed, how we can get them into work. But actually, if we get that right, we should be able to get it right for everybody, because what about the people that haven't been diagnosed? So it's just also being aware of people's processing speeds, that some people grasp things slightly quicker, but that doesn't make them more capable or better at their job. It just means they might need a little bit more time to get their head round new processes and new ways of doing things. And we're always changing, aren't we, the way we do things now, whether it's with AI or whether it's a new electronic system for dispensing or prescribing.
So it sounds like giving people the time and the space to process changes, to maybe ask questions, to try things out before it's fully rolled out and implemented. Are those kinds of things might be helpful?
I think we also need to work together to find out what works for each person, because each person who's neurodivergent won't be the same as another individual. So what may work for one person may not necessarily be helpful for somebody else. So sometimes you get these sort of stereotypes. People think, oh, you're autistic, you should be very techie then. You hear people saying that. May be true, may not be true. And it may be that some people will grasp a new computer system very easily. Some people may need protected time just to get their head round it. And because it takes time to process, it's not a case of, well, you've been on the training course, you should be fine now. It may take just that little bit longer to get up to speed. And I think that can cause quite a lot of anxiety, because you can feel silly, because you feel that people think, well, why can't you just do it the same way as they can? And maybe they're just more able to grasp it quicker.
Yeah, that's really helpful. So what strengths can neurodivergent individuals bring to an organization?
So I think people who are neurodivergent, they often think outside the box. I don't want to generalise, because I don't think that's appropriate, but I think often they can think outside the box. They think of, they look at a situation in a different way, shall we say, and they may come up with a solution to a complex problem that other people may not see through a more neurotypical lens. So especially in strategy and planning, and I think they really are add value to organisations in innovation as well, and happy to look at things in a different way and challenge the status quo.
That's brilliant. And on the other side of that, are there any challenges perhaps in pharmacy in particular, or in workplaces in general, that neurodivergent people may have?
I think in pharmacy, if you think a busy dispensary, loads of interruptions and multitasking can be, it can be quite a challenge for someone that has finds difficulty in focusing, and because there's a lot going on. The other thing as well is to think about sensory issues. So I think some of us may be familiar with too much noise might affect concentration levels and difficulty in focusing. But it's not just noise, it can be other senses. So it could be very bright lights, flickering lights. It could be, I worked actually in one pharmacy which was next door to the hospital canteen, and every day about 11 o'clock you could smell what was for lunch.
Yeah.
Now that could actually distract someone from their work if they were particularly sensitive to the smell. Quite subtle. That's not something that you would necessarily notice or think about, but it's a challenge, and having to really work so hard to focus and overcome this, it can be very tiring and use up a lot of energy. And that's why sometimes we see people, neurodivergent people, with burnout, because they're having to work so hard to try and keep focus when they've got these other interruptions, shall we say, happening.
Yeah.
And also in a noisy dispensary as well can be difficult.
Absolutely. And what you just said about burnout and, almost trying to keep it together throughout the day,
Absolutely.
Despite all of these
Yes,
other things.
Absolutely.
That just brought to mind for me another question about masking. And, we hear about, I think particularly for people with autism, you hear a lot about masking and how they get through their day. And can you tell us a little bit about what masking is and how that might impact an individual?
So we tend to see a lot of this now with females, with girls, women, because years ago it was thought that it was really boys and men that were neurodivergent or autistic, not girls, because it seemed that girls were able to, shall we say in inverted commas, hide their autism. On the surface appeared to be neurotypical, but they were having to work so hard against a system that was working against them. And that's what masking is. And it also happens with ADHD as well, where people are trying to conform to what they feel is the appropriate norm, but it's hard work for them, and that's the masking, and that's where people, and also if that's the case, they may not get the support they need because it may not be obvious that they need the support.
So it almost feels to me like they're working double hard at work.
100%,
so they're just
100%.
doing their job, but then they're also trying to not allow their sensory difficulties to be apparent to other people, trying to remember the norms of communication and I need to behave in this kind of way so that other people will like me, and so they're doing that all day, things that maybe would come a bit more naturally to other people, they're working very, very hard on. And I imagine that would lead to a lot of exhaustion at the end of the day. Exhaustion
and anxiety, because as you rightly said, in a neurotypical setting, it may be the way they interact, just second nature. But someone who's trying to maybe mimic that, but that's not natural for them, they have to think about it every step of the way.
Yeah.
That's hard work.
Yeah. That's really interesting. So are there any workplace adjustments that can be helpful? I think
one of the things I think is really important is inference in language. We have to be clear what we expect. As a line manager, you have to be clear what your employee is expected of your employee, to make sure that work is carried out as intended, not that something's gone wrong because of inference, and the person, maybe an autistic person, may find that a challenge, but they may not. As I don't want to generalise.
Yeah.
But so I think that's important. And other workplace things to think about is, I think it's really important to make sure that you have that conversation with the neurodivergent employee, so that you're not sort of thinking that would be a good idea because I've read it in a book. I think it's about, if you're going to produce any guidelines or guidance, is co-produce it with somebody with maybe autism, other neurodivergent conditions. But actually, remember, we want to think about being person-centred. We think about person-centred with our service users and patients, but what about with the people we work with? So we need to tailor the support for the individual, not just assume, oh, they'll be fine with that because it's a routine, and autistic people have routines. And I think that's very wrong.
Yeah. I think that's a really excellent point. So it's not necessarily about having one policy. This is our policy on, neurodivergence or whatever, and having an X, Y, and Z thing that you will do or put into place. It may be that you have a policy, but it may be that it would be applied flexibly based on the needs of the individual. And it sounds like that's really what you're saying. We need to be aware that every single person is different. Their needs are going to be different. So the manager needs to really explore that and come to understand that with the person.
That's right. And I was talking to someone who runs an organisation with a lot of technical staff, and she was telling me that many of the staff are neurodivergent, and they decided to introduce a lot more autonomy in the way staff were working. One person just needed to be micromanaged. She said they wanted it. They felt without them. So although it's very easy for some people to say, oh, I don't want to be micromanaged, and they look at that in a very negative way, is that actually for some people, maybe that works. Maybe that made that reassured and provided support for that person, for that individual. So I think it's about being flexible and open to suggestions, and sometimes with small amounts of support can make a considerable difference to how someone feels. And if you were setting up, a new computer system, and you've had ring-fenced time for someone to get their head around, to get groups, there'd be a lot less anxiety around it, thinking, how am I going to do this? How am I going to do that? Because I'm not going to be able to do it as quickly. But if you know your manager is able to support you to get to where you need to go to, I think that's a great help.
Yeah, that's really helpful. So shifting a little bit, I'm thinking now about diagnosis. We know that there are a lot of people who've not been diagnosed in the workplace. Correct. We know that there are a lot of people who probably have some suspicions that they might have some sort of a neurodivergent condition. But my understanding is that if you kind of have to start with an idea of what condition you think you might have. So for example, when you're being assessed, you might say, well, I think I need an autism assessment, or I think I need an ADHD assessment. It's not always easy necessarily to know what condition you might be looking for. So I just wanted to get your thoughts maybe on the diagnosis and assessment process, how that works, and maybe if there might be a better way.
Well, that's right, Melissa. And if you think in school, for school children, you could have two children in a class. One gets assessed by, goes through the channels of a specialist teacher and education psychology. Another child could go through the CAM system, get diagnosed with ADHD. Well, they may have quite similar profiles, and there's a lot of overlap. And when we say these conditions co-occur, then are they completely separate, or are they sort of one of the same? I don't know. There's going to be different people will say different things. But they don't talk to each other. It's as if the educational psychology side of things, teaching says education, and then the ADHD is psychiatry. And I think this is really confusing, because we might find that actually the person with dyslexia is still a child might still have trouble focusing, and they could benefit perhaps from methylphenidate, but that's not the system they're in. They've been diagnosed with dyslexia. It may be that educational support for dyslexia might be helpful for the ADHD child. So I find this, I find the way we diagnose, I don't agree with it. I don't know what we do about it, because to me it seems quite old-fashioned, and I think we need to work on that. Now, for adults, it's very difficult, because I have no idea where an adult gets diagnosed for how they get diagnosed with dyslexia, unless they want to. Obviously, they can pay privately, but I don't really know how else, once you leave education, where you'd get an assessment. It's quite difficult. At the moment, I know that many NHS ADHD diagnostic centres have closed their books because they're full up. Even some of the private ones have. But the interesting thing to note was that when I first started working in the mental health arena, there were still some quite eminent clinicians that said ADHD didn't exist in adults. It was only something that happened in boys, in children. And there were no commissioned services. And I couldn't understand that at all. Well, that's changed. So we are getting there, I think. But there's, I think there's quite a lot to do in that arena. And that's why maybe it's better that we think of it as being neurodivergent, and it captures all these different things, but looking at the needs of individuals rather than giving it a name. Not sure if that's terribly helpful.
Yeah. So it sounds like it's a bit of a complicated picture for an adult who might be thinking that they need some support. It would be helpful to know if they have a diagnosis. It can be difficult for them to find that.
It can be. And I do think, but if we have organisations that have done a lot of work in this area, if they get it right, they should be able to get it right for everybody. Because if you look at what somebody needs, if someone appears to be disorganised, but it could be that they're just overwhelmed, perhaps they are dyslexic, perhaps they don't have a diagnosis, but if you just apply what you'd apply to somebody that was dyslexic, you might find those tools help and support that person really well. So again, it's thinking, let's not look at the label, let's think what the presentation is of the challenge.
Interesting. Yeah, that's great. So you've talked about moving away from diagnosis potentially of a particular condition and looking at someone more holistically. So if we were to move away from the medical model, what would that look like?
So I think we need to be clear that neurodivergence, autism, dyslexia, dyspraxia, they're not illnesses. Different way of maybe interacting with the world, different way of seeing things, different way of processing information. They don't need to be, in inverted commas, cured. So it is not the same as an illness that needs special attention to make someone feel better. So and we need to look at the environment. We need to look at how the neurodivergent person is interacting with the environment and what we can change in the environment to make that person feel more comfortable and included in that environment. So I think that's really important. It's not to say we don't need the medical model. Some people do need that clinical support, and that's really important. And there's good evidence to suggest, the use of ADHD medicines and other interventions as well, and other psychological interventions. There is work being done as well, and other medications that may be useful in anxiety that is perhaps seen commonly in people with neurodivergent conditions.
Yeah. So what do you think about the conversation about autism? It seems like that's moving on a little bit, and we may be moving away from talking about it as one single spectrum and maybe now looking at more distinct profiles or types. Do you have any thoughts about that?
Well, the autism was referred to autistic spectrum disorder for quite a while. I really don't like the word disorder because it's exactly what I've said. And I'd like to be able to get rid of ADHD, having disorder at the end of that, but I'm not sure that's going anywhere soon.
Yeah.
But in the same way, say, autistic spectrum disorder has moved, and it moved at one point to autistic spectrum condition. But as you say, the issue with that is that we used to say, well, one end of the spectrum is severe autism, and one end is high functioning, but it didn't really look at individual support needs. And by looking at profiles and realizing that people have different profiles and it's multidimensional and there's lots going on and there's lots of different areas of autism where a person might need support, we want to tailor it at the person, not just where they lie on a scale. And again, I think maybe that's because it was based on a medical model.
Yeah. Yeah, that's interesting. So you're talking about looking at the individual's support needs.
Yeah,
in a way.
Yes, absolutely. Yeah. Looking at absolutely, because by using a profile of an individual, what's needed for that individual.
Yeah,
not necessarily related to their intellectual functioning. But it's very much about, I think, tailor making adjustments and support for the individual and what's right for, and what that individual wants as well, and working with the individual. They shouldn't feel something's being done to them. It needs to be together. It's shared decision making, as we do in healthcare. I think that's really important.
Yeah, I love that. I do think that's really important.
It's interesting actually, because I've worked in healthcare organisations in the past where I've never forgotten this actually. They were talking about designing a distance learning module, and I mentioned that we need to make sure that it's not just about reading. We have to make sure we break it up, because people who have got whether it's ADHD or dyslexia, they might find that's too much reading. Anyway, they were suddenly silenced in the room, and they said, "Oh, yes." It was as if the subject matter was about the patients. That's when you're divergent, but they hadn't considered that the people actually doing the course when you're divergent.
Right.
So you can sometimes find you need reasonable adjustments, even if you're putting on a seminar. If there's not enough breaks for people to absorb the information. I went to something also a while back where there were so many talks. They asked me to fill in a sheet at the end of the morning. I couldn't remember who spoke about what. Now, if someone was having trouble processing all that information, it would be a bit of a waste, wouldn't it? So I think we need to remember that everybody around us, we don't know whether, it's about individuals, isn't it? And remembering it's not just other people and it's not just patients, it's everyone.
Yeah, absolutely. So looking at our staff,
yes,
our colleagues,
yes,
and thinking about that, I think that's really, really helpful. Now, we had a chat before the podcast to kind of think about what we might cover, and you mentioned at that point neurodivergence in menopause. Now, I'm aware that that's probably quite a big topic and we can't necessarily cover it right now, but are there any sort of little nuggets of information that you could discuss?
I'm going to give you a little nugget, because that's another podcast in itself. I don't think I can do that today. What I will mention, and you may have seen this, there's been quite a bit about this recently, about women with ADHD, thinking about the hormones, how they can, the brain fog that comes with menopause, and making it harder to focus. So, and also the emotional, maybe not being dysregulation, not being able to regulate emotions so easily, and it's particularly saying women with ADHD. And I was reading about something recently about women being diagnosed with ADHD at the time of the perimenopause. So that's something of interest. There's a lot more I could say. That's just one little nugget. And again, people experience menopause in different ways. Yeah. But I'll talk about that another time. Maybe you'll invite me back and we'll talk about that another time.
That would be an interesting one. Yes. Okay. And I've become aware recently that there can be some crossover between some of the neurodivergent conditions that we've discussed and OCD. And I just wondered if you might take a minute to talk about that, because I think it's something that not a lot of people are aware of, but it might be really helpful for pharmacists to get a little bit of an understanding about this.
Okay, that's a good question, Melissa. It's an interesting one. Obsessive compulsive disorder. It is a disorder, whereas before I've just said to you, I don't like the word disorder. It's a treatable mental health condition. It's not just a learning difference. And there is a difference between autism, where I think sometimes people have some obsessional interests, narrow field of interests. But with OCD, there has to be an obsession which leads to a compulsion. And without carrying out the compulsion can lead to extreme anxiety. Mm-hmm. Now, this is a very big topic. So I'm only going to just mention one type of obsession, which is something where is quite a common one, but by no means the only type. So a person could be obsessed with germs. The compulsion is hand washing. And I have seen in practice an autistic boy who developed hand washing. This was new for him. It was a new episode. It wasn't his typical obsessions. And he was treated successfully with sertraline, and the obsessive compulsive disorder did go. It resolved. He still was autistic with certain obsessions around certain interests he had, but he wasn't unwell with it. So there is a difference, and it's important that we understand the difference to make sure the person gets the right treatment, because it's a treatable condition. I think it's complicated sometimes by the autism, and that goes for many mental health diagnoses. Sometimes there's a delay in actually getting a diagnosis because it doesn't always present in quite the same way. So that's something to bear in mind.
Okay, so worth understanding that if there is a compulsion that goes along with some sort of a obsessive thought, and it's interfering with daily living, or it's causing a lot of distress, that would be a time to seek help, because it can be treated and resolved.
But you're absolutely right. If the person is not able to function in the way they'd want to function, if they're not able to go to school or go to work or go out to socialise with friends, so yes, absolutely.
Okay, that's great. So as we sort of move towards closing, if listeners were to take away one practical thing, so something that they could do themselves or something they could do within the workplace, what would you, maybe that's two questions. What are the things that somebody could do for themselves, and what's a practical thing that a workplace could do? What would you most recommend that people take away from this podcast?
Well, I think one of the most important things is less focus on that the individual needs to change. The focus should be on, is there a mismatch between the environment and the systems and the individual? And perhaps we can do something about that. Perhaps we can make some reasonable adjustments that in line with what that person would like, to make that person feel more supported. But also, it's not about making an adjustment and then walking away. Follow it up. Did it help? Was it great? Because it may be that by sharing that as well, the other adjustments with other staff, you might find that there's other people in a similar position, and line managers might like to use that tool or that adjustment for other people as well. Obviously, I'm not talking about divulging, something that's personal, but it may be to share good practice is probably what I'm trying to get at. It's just, I think that's important across an organisation, but open to flexibility and not decide, it worked for this person, so it must work for that person, because that's not necessarily the case.
Yeah. Okay, that's great. Thank you very much. Thank you for your insights. Thank you for joining us today, coming all the way up to Manchester. It's been really good having you here.
Thank you so much. I've had a really, really good morning. Thank you.
That's brilliant. Your insights on neurodiversity, inclusion, practical workplace support, they're really, really valuable. And I think that it'll make a big impact for individuals, and I'm sure it will leave our listeners with lots to reflect on and take forward.
Thank you very much, Melissa.
We always hope that our listeners are feeling inspired to bring about positive changes in their own lives. So if today's podcast has resonated with you, you'll find further well-being information, videos, and online content on our website and on our wellbeing learning platform, which is available to pharmacists, pharmacy students, and trainees for free. For further information on our support services, please click on the How We Can Help link in the podcast description. Please don't hesitate to reach out if you feel you may need support. We want to continue providing our free and confidential support services and to open up conversations like this to ensure that no one in our pharmacy family faces challenging times alone. As an independent charity, we rely on donations from individuals and organizations across the profession to enable us to do this. If you're in a position to do so, please consider making a donation today. You can find a QR code at the end of the video, or there's a link in the show's description. Donations help us to provide our essential services, including our counseling and peer support, financial assistance, and more. Thank you so much for listening, and we look forward to seeing you on our next podcast.